Why are IMGs bad? Why is there a certain degree of avoidance of hiring IMGs? Why does system systematically avoid us? Okay, let me tell you a story. When I started out as an IMG doctor in the UK, I'll be honest, I knew how to take a history, examine a patient, and do a few basic procedures, but that was about it. I had no idea how to use a pager, how to properly communicate with the nurses, and how to explain things clearly. I didn't know the unspoken rules of hospital hierarchy, how to ask for help from seniors, or even talk to the juniors. And yes, I had my fair share of complaints. Looking back in those first few years, I probably would not have hired myself as a doctor. But the truth is, things change. You grow, you learn, and you move on. The data shows in Australia, IMGs are 24% more likely to receive a formal complaint, often related to communication or prescribing errors. But the patient outcomes, very similar to locally trained doctors. In UK, IMGs are more likely to be referred to investigation, but they're not more likely to be sanctioned once the case is reviewed and finalized. Often it's about the system unfamiliarity or not the clinical incompetence as such. What about the US, the big place? The IMGs make up 25% of the workforce, but only 20% of them are subjected to disciplinary actions. And they have got better patient outcomes when even it comes to the mortality rates. Yes, better outcomes. So why are we still seeing higher complaint rates? Why are IMGs undervalued in healthcare system that actually need them the most? Let's break it down. It's not just the stat, but the real experience of being an IMG. So I'd like to delve deeper into why are IMGs bad? Why is there a certain degree of avoidance of hiring IMGs? Why does system systematically avoid us? Let's look into some of the information related to that. So without further ado, let's jump into the video. Are international medical graduates a bad choice for countries like UK, US, Australia, and the Middle East? Now, we all know about that international medical graduates or IMGs are struggling to find jobs in the UK. Amongst them are the junior doctor and anesthesia doctor, and they're particularly affected, and I'll tell you why. Why have I mentioned these two in particular? Because the recent Ling review in the UK proposes training pathways for physician associates and anesthesia associates instead of hiring doctors. That takes me back to 2003 when I was in the UK, and just after passing PLAB, we used to say that NHS cries about having no doctors or doctor shortages, but there are hundreds of IMGs sitting jobless in East Ham in London alone. Why not hire them? The answer is simple. Many systems don't like relying on IMGs. It doesn't look good when a country can't produce enough of its own doctors. But here's the real question. Why can't they? Why can't they produce their own doctors? Every year, thousands of the UK, US, and Australian citizens want to become doctors, and they can't get into med school because the competition is so tough. Anyway, I'm getting into a rabbit hole here. So today we'll ask, are IMGs a bad choice for countries, or are they really a part of a bigger solution on medium and long-term basis? So I'll divide this conversation into few main chapters. Number one, IMG's number in actual UK, US, and Australian market. The quality of IMGs, is that really important to have quality IMGs to begin with, or does the quality come as the time passes on? What about the good and real bad IMGs, which cannot be modified despite the time and training? Is training really important? We'll talk a little bit into that. Why replace IMGs with physician associate, especially in the NHS, the way NHS is progressing? And finally, I'll lay out my conclusion for you to make up your own mind. So let's start off with the first topic, which is IMG numbers in the UK, US, and Australia. In the UK, around 40% of the NHS doctors are IMGs. That is over 100,000 foreign trained doctors. In 2023 alone, over 12,000 IMGs applied for GMC registration. In the US, IMGs make up to 25% of the physician workforce. That's huge. That is around 7,000 to 8,000 IMGs matching into residency every year. Over 200,000 IMGs are currently practicing in the US, and this number is actually growing. What about in Australia? A far smaller market, but still significant. About 35% of the doctors are IMGs. So if you look at and compare it with the US market and also with that of the UK market, it is somewhere in between. So it's not percentage-wise any smaller than the US and UK. More than 3,000 IMGs have been able to gain limited or provisional registration here in Australia on annual basis. Middle Eastern countries like Saudi Arabia, UAE, and Qatar, up to 70 to 90% of the doctor workforce is foreign trained. Now, many IMGs work in rural, remote, or high pressure settings where from outback clinics in the Australia to inner city ER or EDs in the UK. These places are where local doctors often don't want to work or they just avoid. And some of these IMGs take up this position and then go on to become college president, inventors of medical devices, leaders of national health programs. So it's clear IMGs step up into the jobs that others won't, and often they rise themselves from their learning from the very bowels of the system. Quality of IMGs. Now, let's be honest, the quality of IMGs varies, but the system they enter also matters. In US, IMGs who pass the UMLE are given full training from intern year to fellowship or to becoming an attending or a consultant. That means that they are often equal, if not better, than the local graduates just by the virtue of having a very diverse experience. First from India, Pakistan, or Bangladesh, where they're coming from, and then on top of that, they get the US experience. So they get the best of the both worlds. In the UK and Australia, many IMGs are brought in for service, not for training primarily. They are expected to already know how to work in a semi-independent format. This creates gaps, not only because they are bad doctors, but because they are not given a fair training runway. There are good IMGs and the bad ones too, just like any other profession. But the biggest issue is the communication. And here's the real example. A doctor messages me, I am MRCP gynecology doctor. What are my chances? That's poor introduction. Now compare, I'm an ONG doctor with 5 years of experience in a tertiary hospital. I've recently passed MRCP-I and completed advanced procedures in obstetrics and gynecology. Would I be correct in assuming taking AMC1 would improve my chances of getting a better job in Australia? Same person, same context, different way of asking the question. All boils down to the way you communicate. Better communication, better results. These very small and preliminary communication really set pace for the how you're going to develop over the years to come. Now, good IMGs improve fast, they adapt, and often they become better than ever in their own home countries. What about the training? The training programs are hard to access for IMGs. In the UK, about 7,000 IMGs doctor enter, but only a small number are able to get into foundation or course specialist training. Many start as non-training service role. What about in Australia? Only 15 to 20% of the IMGs get into pre-vocational or vocational training within 2 years. In the US, in 2024, around 7,500 IMGs matched, but over 5,000 IMGs did not match into any training program. So the message is clear. The training is not automatically granted and falls into your lap. Even in the US, with all of its structure and thousands of capable IMGs are left out. So why replace the IMGs with PAs? Why is the UK hiring physician associate or physician assistant instead of hiring more IMGs? The answer is cost and control. The trained PA costs less than an IMG, and it's easier to standardize their workflow. According to NHS figures, there are now about 3,000 physician associates in England. The Lang report recommends expanding PA. So how are they going to do that? By having much clearer training pathways, their titles, and more specific responsibility. It seems from the system's perspective, a UK trained PA may be better than half prepared IMGs. And with technology, checklist, and standardization of the protocol, the gap may be closing down. The key, the patients want fast and safe care. And if a PA can give that specific care, same hospital would prefer that option because it comes with a lot less baggage of organizing for a visa, further training, structuring, the communication is not quite good. It's just a no-brainer for them. So what is my conclusion? Are IMGs a bad choice? No. The data shows that many IMGs have led hospitals, innovated procedures and tasks, and cleared the pathway for many other new doctors and improved the health standard. They've served where no one else would go. But the recruitment is changing. Systems are now looking for high quality IMGs, good communications, adaptability, and skills that PA or AI can't really easily replace. It's no longer just about being an IMG. It's about being a kind of IMG who brings more to the table. That's the future. Look after yourself and each other, and I'll catch you in the next video. Goodbye.